Okay, so the recording has started. Um, Good. Okay, you're recording as well. All right, so 10 o'clock sharp, let's get started. No more Congolese time. We just hopefully get started now. I want to share my screen. I'm just going to do that now. So share screen two. Okay, and then we share. Hopefully you can see the screen too.
Yep.
Okay, so that's the presentation. It should say how to get into medicine.
hmm
Okay, so we're gonna get started. This is yeah, the whole idea behind this really was to do something educational, try and motivate people, especially now with the sort of summer holidays getting started. People have finished their exams. They've gone on holiday now, so hopefully this will be useful for people who watch it. We're going to cover lots of different things, but hopefully there'll be time for questions at the end or between the slides that we're going to have. Hopefully 10 minutes presentation. We're going to have 6 presentations, hour and a half. We should be fine. So let's crack on. So how to get into medicine. This presentation is going to talk about lots of different things. So the aim is to explain the role of doctors and other allied healthcare professionals, explore advantages and disadvantages, and routes into medicine, healthcare, and allied fields. The importance of education and career options. I think that's more important now because of AI, because of the disruption that's happening, and because of the amount of change that there is in society and in our communities. So in terms of health, we need to understand there's a definition which states that it's the state of complete physical, mental, social well-being, and not just the absence of disease. And so medicine encompasses a whole range of things, and it involves a whole range of peoples who help with the diagnosis, the treating, and the prevention of disease. So you don't necessarily even have to be in contact with patients. You don't even need to be a clinician to be involved in medicine. And that's one of the things I really love about it. Okay, so why medicine? Yeah, it's very challenging. It can be highly rewarding. I think, obviously that we look at the sort of, we hear about the figures that people earn, and there is potential to earn really well, but there is also the opportunity to fit it around your lifestyle. So people enjoy medicine for a whole range of different reasons. So, for example, in terms of lifestyle, if you want to be someone who goes to different countries and helps in emergencies, that's something that you can do, in medicine. And obviously, there's an overwhelming need in Congo. There's an overwhelming need in lots of different countries in Palestine, in all different countries all across the world. So there are disadvantages. It's politically sensitive. There's lots of risk of litigation, so people can sue you. You mistreated someone. You gave someone a medication that had an adverse reaction. That can obviously cause a problem. But there's also risk of NSI, non a needle stick injury. And then there's this impending risk with AI and the possible AI replacement for everybody, as we're being told every day. But I think doctors and clinicians have the greatest possible human impact. If you help someone, fall pregnant and have a child, that can be an amazing life-changing experience. You save someone's, life. It can really bring people very close together, and the relationship between a doctor and a patient can be the strongest relationship possible. Not to exceed obviously the relationship between a man and his wife, or two partners of any sort of gender, but this is what we sort of aspire to in terms of having an impact in people's lives. There's lots and lots of careers, and so I think there's a role for everybody, or every expertise, every talent, every sort of area of interest. So I think there's opportunity, and opportunity abounds. So yeah, you shouldn't necessarily limit yourself. Oh, I didn't do so well in my exams. I can't get into medicine. No, I think there's every opportunity you can get into medicine. And you always hear stories about people who started off as, say, janitors, and then they became, managers, or they became, doctors and nurses. So I think it really is possible. In terms of becoming a doctor, the definition is from I think the Oxford Dictionary, or Webber's Dictionary, but essentially you treat people who are ill. But it's also someone who teaches. And this presentation is part of teaching. So we're teaching or encouraging people about how to get into how to get into these different careers, and how to make a life as a doctor or a non-clinical person. And sometimes the non-clinical people, they earn even more than the doctors. So it's not always about, income. It's also about interests, expertise, and what you want to do, and how you want to be remunerated. So in terms of famous Congolese doctors, this is one of the slides I really liked. I was looking up all these different people, and they were very inspirational. So we had this Dr. Mukwege, I think everyone knows. Dr. Esperance Luvindao is a slightly newer sort of doctor on the scene. She's been around in South Africa for a long time. She's the Namibian health minister, and she's sort of extensively trained. But one person I'm really proud of is Dr. Jean-Jacques Muyembe Tamfum, a microbiology specialist and leader of this treatment for Ebola. So yeah, there's lots and lots of inspirational Congolese doctors. I think even more that we don't know of, who are doing great things, and we should believe and be confident in our own ability to achieve and make a difference. Whether it's where we are, whether it's in Congo, it's yeah, there's a great opportunity there. Okay, so in terms of specialities, there's so many different areas of medicine to be involved in if it's the clinical role, especially if you want to be a doctor, you want to have hands on patients, or even if you don't want to have hands on patients, you want to just do research, you just want to treat people's mental illnesses, or you want to use gadgets and things to perform procedures. And yeah, there's a whole range of different skills and knowledge bases that these people need to have, and it's always evolving, it's always changing, and that's why you always have to keep on studying. But yeah, there's a great breadth and depth of knowledge and skills that are required. In terms of getting into medicine, this slide is slightly old. I know that the GCSEs and the A levels have changed into ones and nines, ones and tens, or something. So, but essentially, it's the same thing. You need to score sort of 70, 80% plus in most of your exams to stand a good chance and in terms of getting in. The admission criteria is fairly the same most places. They do accept baccalaureates. They do accept, there is an access to medicine program. I think in a few different universities offer access to medicine. It's not widely spoken about, but I think it was developed in the late 90s. And so I think King's College is one of them, but there are a few of them. And then some people go via graduate entry programs, so mature students who've studied, say, in a different field. They go in via, oh, hold on, oh, really? They go in via different routes, and then they can become doctors in their own right after the 4 or 5 years of studies. Okay, so you need a good academic record, you need good references, you need to complete a UCAS application, a good personal statement, a UCAT exam, you do an interview, and the interview, in my experience, was an OSCE. OSCE means Observed Structural Clinical Examination. Not necessarily clinical, but you go on to various stations. I had to do like 4 or 5 stations. I watched the video, I gave feedback about the video. They asked me about different questions about different things, and why I chose medicine, all this sort of thing, standard questions, but then some unexpected questions as well. And so they look for someone who's got good communication skills, someone who's got a passion for the job and uh, what it takes to be a doctor. And yeah, I think if you can prove that and sort of demonstrate that sort of in one-to-one, then yeah, you stand a good chance. In terms of progression is long, and people study often for many, many years to become doctors. If you look at the bottom, there's a timeline from when you get into medical school to when you complete your specialist training. And currently in the UK, it's 10 years. When I entered, they were talking about making it slightly shorter and making it sort of down even to 3 years, but it's a 4-year training course. And so this may actually be wrong at the bottom there. So when you finish your foundation training, it's a further 3 years. Oh yeah, no, they're going to make it 2 years. It is 3 years, yes. They're going to make it 2 years instead of the three. And that's Usually because we don't have to do very many procedures. The knowledge base is still there, but the procedures that we have to do is less than most other specialities. But if you want to be a surgeon, if you want to sort of be to do so orthopedics, often you finish your training and then you have to do a further, year or two or three if you want to get a PhD. If you want to get onto a specialist, like program, it can be very, very competitive and very, very difficult. But it's possible. People are doing it all the time, so there's no reason not to endure and persevere if that's something you really want to do. Terms of tips and hints, yeah, I believe faith is really important. You need to have faith in yourself. You need to have faith in a higher power. You need to have, be highly determined and highly motivated, highly disciplined, and very proactive. Um, yeah, yes. I mean, it is very challenging, and it is challenging for a reason because the career itself is challenging. So if you go in, and you take it for granted, it can be misleadingly easy, for example, and then you end up with a completely unrealistic view of what's expected and what the challenges are, in being a clinician. But yeah, you can find a mentor, or you can find a coach or a tribe, a group of people who have shared values and shared belief and who are able to help you and guide you, because that's what really can make a big difference. If you don't have anyone to guide you, it can be very, very daunting and challenging. But so you can set goals, you achieve standards or establish standards, build on strengths, reduce weaknesses, revise and improve. And it's very, very possible, I think, for more people than we would like to think. But yeah, in summary, medicine provides evidence-based treatment for good health. There's many advantages, but yeah, if you are in the top 5% or 10%, you can do really well. But not everyone does really well financially. And sometimes it's not even about the finances. It can be about the experience. It can be about, using your gift and making a difference to the lives of people. And there's various routes to enter medicine. You have to provide evidence of excellence and commitment to learning. I think those are the two main things if that's what you want to get into. But that's about how to get into medicine. Okay, this is some more information. Doctors to Be, it's a very old BBC series. They also made books about it. Seven Habits. Dr. Stephen Covey just talks about attitudes, mindsets, faith, and beliefs that can help in terms of overcoming obstacles and challenges. There are organizations out there that help people get into medicine. There are other sort of non-profit organizations that have that focus as well to help students, to help women, to help men, and so on. So I think there's lots and lots of help now more than ever, and you can definitely read about it online. That is my talk. Thank you. Do you have questions? Okay, so oh, how do I get you to unmute? Unmute? Us to unmute. Trying to get you to unmute. Okay. Hello, Joyce. Go ahead.
Hey, Doctor. Hey, everyone. And everyone, to everyone I haven't met. Obviously, I know Doctor, but my name is Joyce Masasa, and my presentation is going to be on my work, my careers journey and my current role at the Royal Society of Medicine, which is where I'm currently at. Go ahead, take to the next slide, please. Thank you. So here I've just to give like everybody more on kind of just a little bit more about me so you can get to know me, of course, beyond like professional. So I'm an eldest daughter, first daughter of four sisters. I'm from Congo, born and raised in London. I'm a Christian. Just love spending time with family, loved ones, going to concerts and traveling. I love to eat as well, so I love some food and like to encourage people and just support their well-being. I think that's a lot about me. I think it also comes from me being an eldest daughter, so I think it's just a part of who I am. So I love to support people and just encourage them just so that they can be their best versions of themselves. Next slide, please. Thank you. So yeah, so on this side, I'm just going to talk more about my career and kind of how I've got to where I am and how I'm working at the RSM now. So I kind of miss, I just started with university because I've been, of course, being born and raised here, primary, secondary school, A levels, and then obviously here. went to University of Portsmouth and I studied marketing with psychology. Initially, I was going to do psychology solely, but then I think just the creative side of me was kind of like, it'd be interesting to learn like kind of how consumers behave, why people do what they do, but on a communicative level. Like, so why and how we can communicate to people depending on their behaviors, depending on their interests, and how we can communicate to them effectively with products and services that we create or work with. So that's how I went for marketing psychology, and I finished that degree in 2018 and achieved a 2-1. And here I am now, and just started off my journey in terms of my career. So, why is marketing psychology? I would say, so I've always had a fascination with why people behave the way they do, why people kind of decide to do what they do, how people think, why people feel the way they do, why people act the way they do. So, I think that's what steered me towards psychology mostly. And then marketing obviously brings in that kind of the communicative side, the creative side. So, why we create certain products and services for a certain kind of person or for a certain kind of audience. So what's the difference in between marketing to like a child or a young person or an adult and things like that. So that's why when I saw this degree, I thought, okay, this is definitely a bit of me. It'll be good and fascinating to study this. And that's why I chose to study that. In terms of my journey, I began on an assistant level. So I was at a charity called Small Steps, which is based in the Angel side, and they just work towards they focused on collecting shoes for like young children in third world countries. So then I was doing kind of the marketing for them on that front, and that was just like a volunteer role. They actually informed me a lot. I got to learn more about marketing, so kind of beyond my degree and actually take on responsibilities and tasks that help towards achieving their goals. Then I went on to kind of perspective research, and that was more kind of marketing, but on the phone. So we're calling people up, kind of cold calling a little bit, but even that was just another kind of form of communication and learning how to like talk to people, get them to want to work with us, want to kind of use our products and services and things like that. Then I went on to Informa, and then went to ICAW, which was kind of beyond the assistant level. So now I was kind of going to a level where I'm getting more responsibility. So ICAW, that's the Institute of Chartered Accountants England and Wales. So they're like a financial based company. And over there, I was part of a team where we worked on the communication side of things in terms of the events they did. So they focused more on events for people who were going into like accountancy, working in accountancy, students, trainees in accountancy, and that opened me more up to marketing and what comes with it. So we used to do webinars, events focused on the accountancy and kind of how they can continue to go up in their career. Then when I finished in that role, so that was I finished that in April 2022. Then May 2022, I started at the Royal Society of Medicine, and that was a whole different realm because while I was at, I knew from my ICW role that I didn't want to move on. I wanted something completely different from working in finance. And then because of that interest I had in psychology, actually, I feel like the Royal Society of Medicine just ended up being the best place I could go because they work with, as Dr. showed previously, literally all the specialties that he listed. We work with all of those specialties. So there's 55 or 54, I believe, all those specialties. So it'll just be like a doctor, a nurse, anybody, any kind of health professional that wants to put on a course or a webinar or an event with us. We help them kind of put that event on logistically. And then my team that I work for, we work on the marketing side of things. So just supporting their promotion, ensuring that we're catching the audiences that be interested in joining the event or attending. So that's where I am now. That's my RSM role. Yes, so here I will just talk more on the role that I'm at. So for anyone that doesn't know what the RSM is, the Royal Society of Medicine, so when membership organizations, so if you were to join, you could become a member if you like. Obviously, if you needed a bit more, reasons as to why to join, you can still take part in webinars and events, but obviously you won't reap the benefits as those who are members. But we're a charity and the people that work with us, they are able to put on events, educational events, webinars, courses that help healthcare professionals in anywhere where they are. So we work from people who have retired, trainees, students, fellows, and just a whole different realm of kind of membership. So just more on the role. So I'm a part of a wider team. So I'm working in the marketing team, but I'm a part of the engagement team. So that includes designers, that includes our communications team, that includes our head of. So all of us are basically responsible for the marketing that is done by the Royal Society of Medicine. And my role includes creating campaigns, strategic campaigns, digital campaigns for the promotion and the support of the events that we put on. So that can be internal events. So that'll be our educational events where we are working with doctors, health professional, clinicians that come to us and they brief us on what the event is and what they want when they'll do it, who to target, and then we'll just help them on the promotional aspect. So from the concept of it all the way to the completion and the day the event takes place. And then we also provide them with kind of post-event information at how it did compared to maybe because some events that we have can be annual and some can be people that have just come and they're putting on an event for the first time. So it's a wide range. So sometimes we have annual events, like some of my specialties that I work with include ophthalmology. So they have two annual events that they do every year, whereas there's some that, so Venus, I think for people that work in the Venus field, they only have like this one annual event that they do where there's others. So respiratory medicine, for example, they have like a 6-part course that people can come on and join and learn like kind of on I think it's like a bi-monthly basis. So they have that throughout the year. And then there's others, dermatology, for example, that we also work with. They have like an event every single month, for example, at the end of every Thursday. So just depending on the specialty, that's how we help them put on the events. But it's exposed me to quite a lot of information, quite a lot on that kind of the medical field, the different specialties. 'Cause I don't even think I realized the width and the breadth of medicine because we only hear doctors and it's just like, oh, okay, like Doctor said before, just somebody that treats an ill person, but there is so much involved in it, so many areas. And I think definitely, as Doctor said before, like something for everyone for sure. So it's been very interesting and educational so far and fun actually as well. Some of them are very, like I've had meetings with some professionals who have either they've come from surgery or they've left the surgery and then come into the meeting and just casually say like, oh, I've got an open this, that I need to get back to. And I'm just like, wow. And they say it so casually. And I'm just like, how are you, you're cutting someone open or performing an operation, but it's so, I guess because they're so used to and it's just their profession and what they're passionate about is just it's second nature to them. So it's been very fun and interesting. Oh, next slide. Sorry, I didn't say that. So I just put here some top 3 lessons that I've learned over time. So my first one is that growth comes with discomfort. And what I mean by that, just to expand, is that I think sometimes in any realm of work that you're in or any work that you're doing, I think it is easy to become comfortable sometimes. But I also believe that it's important to understand that if you do want to grow or do want to kind of reach this certain potential that you probably know you're aware of that it will come with discomfort and there's nothing wrong with that. I feel like when you welcome discomfort you are allowing yourself to propel to like just a new height and maybe a different area that you didn't even know you had the potential to be great in, but then you go into it and you even excel beyond what you thought. My second one is just building your network and connecting. I think it's important. As they say, I think there's a saying, I don't even know if it might be British, it might be American, wherever it comes from, but your network is your net worth. So I think it's important to connect, even as we've all gathered here, like just to connect, share ideas, share thoughts, share opinions, because, we don't always know everything and you can connect and be mentored and coached and learn something that you weren't aware of. And you can also become in a position where you're able to show somebody else something as well. So I think it's very important to connect and build your network. And that way as well, you may be able to be exposed to opportunities that you may not have had you not had the network you have around you. And the final one for me is just trust the process. I think for this as well, it does um include faith in it for me as well, just trusting yourself, trusting your direction. And I think if you're clear on your goals and your ambitions and the direction you want to go, and you have, the good right people around you, and you know that these are the steps I need to take to get to where I want to just be trusting of it, trust in the direction you're going, trust God, whoever you believe in, and you'll reach where you want to go. But yes, yes, I think that's my final slide. I think there's a
Okay.
next one, but I think that's just my thank you. Yes.
Okay.
I just
Amazing.
put my LinkedIn on there if you like. Feel free to add, connect. Let's connect. But yes, thank you all. Thanks for listening, everyone.
No problem. Thanks a lot. Lot choice.
No
I
problem.
had a question for you because I was
Yes,
thinking about it
please.
a while.
Yeah.
Um, I mean, the talk isn't about AI, but AI is important. It's a looming threat, so
Yeah.
to speak. But
Yeah.
what are your thoughts on AI? Are you using it currently in your work? And what recommendations do you have about people, for people who are worried about AI taking their role and not going into,
Mm,
the sort of courses at the
yeah.
moment because of the threats of AI? What are your thoughts and recommendations?
I think, well, to be honest, because I work on the marketing side of things, for me, this may be biased of me, but I think that AI is not so problematic. I think it can be a useful tool. It can be helpful. It does kind of remove sometimes like a kind of the manual side of doing things. It can be fast, but it doesn't take away from, I don't think it not doesn't, but it shouldn't take away from, I think nothing can be just like manually doing something, somebody thinking something and doing it themselves. I think it's just a helpful tool, just there to support. It can be good, obviously, especially for the times that we're in now, with everything is so fast paced. We're in a fast paced time, fast paced environment. AI is helpful. It's a helpful tool, but I don't think it should replace kind of the way people just naturally and manually do things. Just as a supporting tool, I think it works. It's a healthy one. So I'm not against it, but just use with caution.
Of course, of course.
Yeah.
Okay, that's great. Yeah, I mean, I could talk about AI for a while, but
Yeah.
I'm encouraged by what you said because I'm sort of mindful that everyone's saying that it's going to replace all our jobs when none of us are going to be employed. So
Gosh.
yeah, it's I think as long as there's a need for human connection,
Yeah.
there'll be jobs for us. So it's just a question of using it as a tool as opposed to maybe having it replace us entirely. Although some people are wishing that. But no, thank you for the presentation,
No
and
problem
I think
at
we can
all.
hopefully go to the next slide. One problem, we've had a bit of a crisis. Uh, Sterling, my brother, was meant to join us, but he's held up at work and unfortunately he won't be able to join. But I'll be able to do his presentation for him. So hopefully, it will still be useful. I'm not a I'm not a practice manager, but I'll go by what he has sort of put on the slides. Okay, so practice management. I'm still in Tampa. Um, so he's been a practice manager, I believe, for a good 5 years now, at least. So this is what we wanted to talk about, just giving a bit of an introduction into practice management, how to get into practice management, the different roles and responsibilities you can do once you become a practice manager, what the career prospects are, and the current trends, and AI and practice management. So yeah, this will maybe not be as comprehensive as it would have been if you were to do the presentation, but hopefully we can at least take something out of it. And he obviously sends his apologies because he's had a crisis at work and he's not been able to join us, unfortunately. But we'll persevere, we'll carry on, and hopefully he'll join us next time. So what is practice management? Anyway, initially, he is an assistant practice manager at Lucas Avenue. It's a practice in Ilford, East London. He was previously a practice manager at our private clinic that we had set up in Barking, and he had helped me for a good 3, 4 years with setting it up, running it, and the challenges that we faced. But unfortunately, we had to close it down. So there isn't a physical practice anymore, but he's still currently working, and he's been practice manager at Lucas Avenue. He's soon to be a lead practice manager, maybe at the same place, maybe somewhere else. He's sort of deciding what he's going to do. But he's a graduate from Royal Holloway University of London, where he studied human resource management. So any sort of management or administrative qualification can help and set you on the path to getting into practice management. In terms of getting in, there's lots of different pathways. Some people start as secretaries, some people start as receptionists, and then they get promoted from within. Or if you have a qualification, that can also be a point of entry. So yeah, a data officer in a surgery or clinic, different responsibilities. And then once people see that you're competent, that you're professional, that you're courteous, you're kind, that you're a leader within the group, then that often opens the opportunity for people to recognize the talent and then promote you from there. And I know a few other practice managers or assistant practice managers who have started in that way. Qualifications that can help. You can get a diploma in management, certificate in primary care management, and you can do this leadership academy programs either online via NHS e-learning portals, and that can set you on your way. But apparently, if you volunteer your time, that can also be a way to get your foot into the door. So I know people don't like to volunteer, but volunteering can take you far because you build that relationship. People see that you're serious, they see that you're committed, they see that you're hardworking, you're ready to give up your time, and you have good people skills. The roles and responsibilities of practice management. So, obviously every day is different. They have to have contingencies for different things. And they help the doctors and the nurses and the clinicians in terms of the day-to-day running of the practice, ensuring that, they have the right materials, they have the right they have the right number of staff, they have, different plans if people are away, if people are ill, if there's a crisis, there's an emergency, there's one thing or another that can happen, and that can mean that people are indisposed. And they run the meetings, they take minutes, and then they file the minutes, and then they help with finances, banking, and hiring and firing people. They review targets. Obviously, we have QOF, and they play a big role in making sure that people are able to get paid through QOF. QOF is a system for identifying quality quality outcomes, and then you are compensated. Each practice that has patients from the NHS gets paid according to the QOF points that they generate. So this is a yearly thing that happens. And oh, Papa Junior, could you? Yes, thank you. So it's just a way of matching outcomes with finances, and that's one of the ways that practices keep their doors open. Because obviously, if they don't make enough money, they can't hire patients, or they can't hire staff, and they can't sort of provide all the services that the patients need and want. Okay, so yeah, the main job is to make sure the practice runs smoothly for the patients and for the staff. Okay, obviously complaints is a big thing. You need practice manager who's going to help with complaints. If there's an issue that comes up, they can then help to address it. In terms of career prospects, if you're a practice manager, then you obviously show that you've got administrative and management skills, which are transferable in any business, any sort of sector, really, whether it's the private sector, public sector jobs. People will be surprised they can pay really, really well, and some of the practice managers can earn more than a lot of the doctors. So it depends how big the practice is, and what we're seeing now is more and more big practices. So you've got these international companies who are investing from North America, not so much from China, but some from Europe. They're coming in, they're buying up practices, and then they're having multi-layers of managers. And if you're a practice manager for a company that has, say, 20 practices, you can imagine you're going to be earning, substantially more than one of the doctors working in, say, a practice. So it's about being competent, being knowledgeable, having leadership skills, being problem solving, and understanding the financial aspects and the human rights, sorry, HR and compliance side of things. Compliance and regulations are a big factor when it comes to having a role as a practice manager. So it's really important that you have the good practice manager who can make a big difference when it comes to making the company solvent and ensuring that the practice keeps patients and has a good reputation and provides an excellent level of service to all the patients. Trends, yeah, so I think I had mentioned some of this already. Private healthcare, digital health clinics are expanding. Many managers retire early, so there's lots of opportunities for younger staff. Leaders are essential for coordination and cost control. Healthcare is very expensive, whether it's for the government or for the practice itself. Hiring locums is very expensive. Hiring staff is very expensive. Utilities are expensive. So, paying for electricity, paying for insurance, paying for all these different things, very, very expensive. So you need to have a practice manager who's on the ball to, prevent problems before they get bigger and because occasionally, if you have a problem with a patient, it can end up costing millions. So if you end up being sued, it can cost a lot of money, and so a good practice manager can make the world of difference. Okay, sorry, we just sort of welcoming more people into the talk. How AI will affect the role. So AI is helping with lots of things, scheduling, analytics, patient communication. So, sort of patient recalls. Recalls are really important. So, they making sure patients come back, routine appointments, for pap smears, for vaccinations, for various things that they need to do. You need a system for communicating. Obviously, it's SMS, text messages, emails. That's reducing the need for phone calls. But that's more difficult for the older population. Patients who are over a certain age may not have the tech savvy to understand and navigate the system. And so it's obviously, younger people that often get the most out of these sorts of communications, these methods of communication. But yes, they also needed to lead people. So they're not necessarily leading machines, they're leading people and ensuring that the people are as effective as they can be, and also dealing with the challenges that come with dealing with people. People have problems, and sometimes you need to help to address the problems, or you need to provide disciplinary action. You need to manage change, all the different changes that happen, one year to the next with the government, with the policies, with the politics that comes out. One year you can do something, and another year it's no longer funded, it's no longer covered or provided, and that needs tact and skill and discipline and leadership. Okay, that was the talk. Hopefully, I've done it justice. But yes, I'm not sure there'll be many questions I can answer, but I can attempt to answer them if there are any questions. Otherwise, we can go on to the next talk, and I think that should be nurse specialist Héritier. Héritier, are you with us? I believe he should be with us. Can you make yourself known? I see him there. I'm going to ask him to unmute. Hello, Héritier. Are you with us? He's with us in name only. I'm going to message him. Hopefully he's around. Let me just give him a nudge. Hello. Oh, there we go. John H.
Hey,
John
can
H.
you?
Building. Hello, hello. How are you doing? I think your slide is next. Are you happy to go ahead? Do you want a few minutes?
I'm ready. Let's do this. Let's do this. Sorry, my webcam is not working properly, so I'm using my phone and I'm also on the PC, so you might hear me double.
Okay, hopefully not, but yes, I'm looking forward to it. It should be interesting. Let's get started. I think your slide is next. John Héritier Tampu. Take the floor is yours.
Good afternoon, everyone. John Héritier, rheumatology nurse. Can you hear me?
Loud and clear.
Awesome. Next page, please. So I'm a rheumatology nurse for the past 5.5 years. I was in Imperial for about 3 years. I recently moved to Whittington Hospital. I'm there now. And before the rheumatology, I was doing hemoglobinopathy, that's sickle cell thalassemia, uh, Royal London Hospital for about 2 years. But I started my nursing job in Homerton, where I spent about 8 years. I was in a medical day unit for 2 years. That's where they do infusions, pain management, and things like that. And 6 years on the ward as a junior nurse. All right. So we're gonna look into nursing career, how to start it, all about it. Okay. Next page, please. What is nursing today? Nursing is dynamic, is a vital profession which focuses on patient care, health promotion, health education, and clinical leadership. And as you know, without the nurses, I think the healthcare system will collapse because nurses are the backbone of the healthcare system. Yeah. And our role is very diverse from hospital, from the ward, community, public health, education, research, travel, you name it. All right. Next page, please. How to get into nursing. So from school, some good GCSEs, A levels, or BTech in healthcare and social care, or as a graduate, no, as a nursing degree apprenticeship, you can actually go through that route, or as a graduate, graduate entry is usually 18 months to 2 years. It depends if you're doing diploma or you're doing masters. And also internationally trained nurses from countries like English-speaking countries, Nigeria, Ghana, and the rest. They can come in to sign up to NMC. They need to prove their level of English, and they will do OSCEs to assess their skills and experience. Next page, please. So, nursing specializations and career progression. As I said earlier, nursing is quite broad, and there's a lot of opportunities for nurses to have jobs globally. So, you can start on the ward, you can go to A&E, you can work in intensive care units, theater, you can work in community as a district nurse or community nurse, you can do palliative nursing, oncology, you can do rheumatology, and there are some advanced roles like a clinical nurse specialist or advanced nurse practitioners. Sometimes when you go to the GP, you see a practice nurse. So that's another job. And also you can become a nurse consultant. All right. If you are very academic, you don't want to go to clinical path, you can go on non-clinical path through education and training or research or policies and leadership. Or if you want to work globally, you want to go international, you can join organizations such as World Health Organization or Médecins Sans Frontières or Travel Nurse, etc. Next. Challenges in nursing. Nursing is a very rewarding profession, but it could be emotionally demanding and draining. Dealing with end-of-life care, trauma exposure, shortness of staff, workload. I'll give you a little story. So according to NMC, nurses are supposed to look after between 4 to 7 patients. That's the ratio of a patient per nurse. But when I started my nursing career in Homerton, we used to have 14 patients. I'm not saying they are all independent. Most of them need all care. And most of the time, we used to be short of staff. Mm-hmm. So if at 7 in the morning, you meant to finish at 7 p.m., but you leave in at 9. Because you have to make sure all the jobs, all the tasks are done, and patients are properly looked after. At the end of the day, you are drained, you are tired. But because looking after people, we love helping people, we come again the next day. All right? And also there is a burden on documentation. There's a lot of care plans, nutrition care plan, skin care plan, this care plan, that care plan. You have to make sure you complete all of them. It could be a burden. But most importantly, maintaining compassion despite the pressure. That's a challenge. You're dealing with the patient family, not patient family, doctors, dietitian, physiotherapists, social workers, and colleagues. It could be very draining, but you have to be very patient. Patient with yourself, patient, with colleagues, and with patients and their families. Next slide, please. There are opportunities in nursing, as I mentioned earlier. There's always this career stability, and nursing is always high, in demand globally. If you decide to leave the UK to go to Canada, to work in Canada, you can go to USA, you can go to Australia, you can travel, you can go internationally and find a job as a nurse. There's opportunity on leadership development. For instance, Florence Nightingale Foundation trained nurses and midwives to become leaders, to shape the future of the healthcare in the UK and in the world. An opportunity to make a real impact on people. When you're working with people who are unwell, you start from the admission, you take them through all the way to discharge. If they recover, they are really well. When they come to you to say, thank you, John, thank you, Pidange, thank you, Joyce, for the care you've given, the help, that is the most amazing feeling ever. It's not about the money. It's about the impact that we bring to people's life. And you also have opportunity to work, cross sectors. You can work in NHS, you can work private, you can work in military, you can work in education or research, you can work with international agencies to help around where there are crises. Next slide, please. So my nursing experience, I've mainly focused on the last 5 years where I was working as a rheumatology clinical nurse specialist. And some of my key responsibilities are mainly nurse-led clinics where we see patients to educate them, to monitor their conditions, to empower them to look after themselves properly, to be compliant with their treatment. I coordinate infusions, and I'm a lead biologic in the rheumatology. So with our patients in the rheumatology, we have different sort of treatments. We have DMARDs and normal DMARDs like methotrexate and all the rest. That's the first line of treatment. If that doesn't work, we have to take them to the second line of treatment. That's biologics. So I usually help patients with that process, from screening, from counseling, advising, and initiation, showing them how to inject and how to look after them there should they have any concerns or have any flare-ups or adverse reaction or allergy reactions. I also liaise with the MDTs. So especially with the biologics patients, we have to discuss all the patients in the biologics MDT. For example, if Mr. A has tried this medication, it hasn't worked, we need to switch him. In most cases, we'll see them in the clinic and then we'll represent them to the MDT to discuss with the consultant and the whole team to see what could be the best options. Lesson learned, nursing, even though it's a very rewarding profession, it could be very challenging. I saw what my colleague here mentioned earlier, Joyce, about communication, about putting yourself forward, team working, being determined, working with people, adaptability, compassion in action. But assertiveness could be a challenge. It could be a challenge. And also leadership, because we are all from different background, different belief system, different countries, and people react, believe differently. Sometimes if you are in that position of leadership, it is challenging to try to accommodate everyone's differences while moving forward with a great quality of service for the team, for the service, and for the patient. Next slide, please. What I wish I knew before I started nursing: emotional strength is required. You could be really drained. Sometimes I remember my days in Homerton, I used to go days without my break. So they book you 2 long days, maybe 1 day off, 3 nights in a row. Is emotionally draining. But you have to find the strength to look after yourself, not just physically, but also emotionally. As I said, the importance of self-care and maintaining boundaries. And as I said earlier, being assertive. If you know that they've given you too much work and you won't be able to give the best of you, you have to voice it. You have to talk. And there are ways to go about it. Nursing is not just clinical, it's holistic. It means you are looking after the patient physically, mentally, and socially. So there's the social well-being. But if you yourself, you're not well enough to give the best of yourself, then this becomes compromise. That's why you have to be assertive. You have to have this emotional strength to look after you, to be assertive, and to give the best of yourself. Above all that, communication is your superpower. Verbally, written, and body language. You have to be able to communicate efficiently with patients, with colleagues, especially the management. Because one thing you need to remember, in most cases, the management are only worried about covering the shift. Most of the cases, they care less about you as a person. I mean, at least if you don't have good management. That's why you have to be very assertive. You have to communicate properly. You have to be able to talk for yourself while advocating for the patient. Because you being not fit to work properly undermines patient care. So it's crucial. And last but not least, learning is everlasting. It never ends. There's always new things. They update guidelines, new medications, new policies, new protocols. You have to keep up. Learning is never ending. Next, please. So, what are my top advice for aspiring nurses? I think it is important to gain early exposure to the profession, to know what is it all about. So volunteer or work as a healthcare assistant. Yeah. Stay very curious. Ask questions when you go on placement as a student nurse. Get involved. Because when you are a student in placement, you are supernumeric. So you are not responsible, you are not accountable for anything. You have opportunities to learn as much. What I observe during my days on the ward, student nurses are very, very anxious, very nervous, even scared to do certain things. Oh, I'm not supposed to do this. I've been told not to do this. My about to become a nurse, learn as much, make good use of your placement, use your mentors, use your time to learn, be curious. And you need to build strong professional relationships with colleagues, with your mentors, um, with doctors. Connect, network, talk to people, be open. There are always different opportunities, different specialities. As my colleague mentioned earlier, you will never know where you will discover or you'll find your hidden potential, your hidden passion. So you have to be open to explore all the possibilities. And as I said earlier, nursing is not just a job, it's a calling, it's a vocation and a career. Next slide, please. Final thoughts. Nursing is the heart of healthcare. It is globally respected and endlessly evolving and deeply rewarding. I know at the moment, if you go to NHS, there might be short of staff because most nurses have left during Brexit, and so many things are happening, so many changes, immigration, change of laws, and all that. A lot of colleagues are leaving and going to countries like Canada, USA, Australia to work. But at the same time, there are so many opportunities for new nurses. You have to be bold enough to come in, open to learn, put yourself forward for any opportunity. You will find yourself not just a band five or a band six, a band seven. You can even become a nurse consultant in a short period of time. You have to put yourself forward. Next slide, please. Oh, that's just my contacts. So we started this platform for nurses called CNA UK, Congolese Nurses Association. It's still work in progress. We're working on it. There's bits and pieces that we're trying to sort out. But what is CNA UK about? Next slide, please. So CNA UK aims to empower Congolese nurses through education, mentorship, advocacy, and global collaboration to help improve healthcare and well-being of our community here in the UK, in our society, in Congo, where we are from. Next slide. This is some of the resources. If you are curious and you want to find more about nursing as a profession, you can visit one of the websites for more information, especially Nursing and Midwifery Council will give you more information, and RCN at the bottom as well. Next. So open for any questions.
I've actually got a question. You might not be surprised. AI is on my mind. So I'm thinking a lot about AI and robotics. Every day we're seeing a new video about robots replacing everybody, AI replacing everybody. Have you heard anything on the grapevine? Is there anything in any plans to have robots doing things on the ward? Have you? I mean, what are your thoughts about that? That's the first question. Second question is more about the nursing community in the UK, especially the Congolese nursing community. We know there are many, many Congolese nurses. I knew when I was working in Homerton, there were at least 3 or 4, maybe even 5 or 6, maybe even 10 in my time, 20 years, 15 years ago, however long it was.
Yeah.
Now, I'm sure on every ward you're going to find a Congolese nurse. What are your thoughts about how we can work together and try and encourage this greater cohesion and greater sort of spirit of volunteering and being proactive, to try and improve conditions for our own community, the Congolese community in the UK, but also back in Congo. Those are my two questions for you.
Okay, so let's start with AIA. AI, it has been one of the things talked about most recently in NHS, and there's quite a lot of work in progress to see how it can be used to help us with productivity. In terms of surgery, I know that there are steps in progress where certain surgeries are probably in trial of being done by AI enhanced robots. I think I've seen few clips about certain surgeries already being tried by AI enhanced robots. But AI itself, I don't think it will replace the human factor in the interaction that we have on a daily basis with patients. If anything, it will be used to contribute to enhance that impact humans have on one-to-one care. That's my take on that. It's not a bad thing. It's not going to take over. It will
Okay.
be in future to help improve quality of care and services, across the board. In terms of the CNA UK and the Congolese nurses, I want you to know that I have been trying so hard for the past couple of years. It, it goes back to 2015. We even started the platform with few nurses. Things were running well, and all of a sudden, uh, most of them lost interest. In 2019, if I don't forget, I joined force with another colleague to create a more inclusive sort of platform called Congolese Healthcare Professional Association, called I think it was CHPA, something like that. The only problem was the lady had great ambitions, but she was a bit selfish in the way she wanted to go about it, and I couldn't find myself working in such environment, so I backed off. I learned that she's still active, but I don't really know much about her. I know a few nurses came back to me asking me to do something because there's nothing going on for Congolese nurses, and that was the reason why I said no. Let's bring this back. So that's why I'm actually reinitiating it again. But in terms of working together with CONDADA, with Congolese platform, I think we would definitely need to create a, a platform where both nurses and doctors and allied healthcare professionals come together, work together for the betterment and for the best interests of the Congolese community here in the UK and back home. I'm very open to explore this with you, Dr. Tampa, and with other colleagues to have one platform where we can all work together. I don't know if I've answered your question.
No, no, that's very helpful. The slides and the presentation was very, very good. I really do appreciate your presence and all your feedback and your answers. Thanks a lot, John. Thanks.
Thank you, Doctor. Thanks.
Okay, okay. So this is we're nearly coming towards the end. I'm not sure if you want to take a comfort break. It's 11 o'clock or 11:02. We can maybe give people a minute or two for a comfort break, and then we reconvene in 3 minutes, and then we finish and wrap up the rest of the talk. So we're just going to have a few minutes for a comfort break. Do whatever you need to do. Have a drink, have a coffee, have some tea, go to the loo, and then we reconvene at 11:05, and then we carry on and we complete the rest of the talk. We're not that far from completing, but I just wanted to just give people a chance to have a breather and maybe stretch the legs if they're just sat down all the time. So I'm going to reconvene in a couple of minutes, and then we'll get started with the rest of the talk. Okay. We're just taking 5, and then we're going to reconvene in 2 minutes. Okay. Okay, right. We're nearly finished. Just two more talks to go, and then the short panel conversation. Hopefully, everyone's had a chance to stretch their legs. Everyone's had a chance to get about and maybe have something to drink.
Let's get the panel.
So we'll just get on to the next slide, and then we'll have our headline speaker just after that. Okay. Okay, so this is me, Dr. Tampa, talking about working overseas in 2025. Hopefully this will be useful. But yes, I'll talk a bit about myself first of all. The agenda that we have is, again, a brief introduction, why working overseas, the options, some potential downsides, how to make the move, and some recommendations. Okay. So, in terms of myself, I am one of more than 8 siblings. I'm a husband and a father of 3. I grew up in Hackney. I'm from Congo and Angola. I grew up in Hackney and Camden from a very early age, 3 or 4 or something. But I was very young when I came to the country. So, if my accent is funny, it's because I came here. I came to the UK when I was very, very young. In terms of getting into medicine, I wanted to get into medicine first of all, but I ended up studying medical engineering. So lots of numbers, lots of calculations, presentations, AutoCAD, lots of very interesting, but not necessarily useful courses that led me to get a qualification as an engineer. At the end or towards the end of my course, I realized that I wanted to do something that was more human facing and more, had a greater involvement in the clinical aspect as opposed to the non-clinical aspect of, medicine. So I was choosing between doing a PhD in engineering or doing an MBBS to qualify as a doctor. And fortunately, I was able to apply and be accepted on the graduate entry medicine program. And then I started my course and finished within 4 years. And that was in 2009 when I finished as a doctor. Subsequently, I did my foundation training, and then I did my GP training in Ipswich in Suffolk. I've been a GP ever since. So 11 some years now. During the pandemic, I did a postgraduate diploma in dermatology. But like nurse specialist John said, learning never ends. You have to keep on doing courses, you have to keep on studying, you have to keep on applying and refreshing your knowledge base. In terms of my life as a GP, it is not that bad. I mean, I finished 2014 and I had some good experiences and some bad experiences. The bad experiences were being a salaried doctor and being the face of the practice but not being compensated as such. So companies that own practices, often they will hire new trainees, they give them a great pitch and they tell them, oh, you're going to do well, you're going to earn lots of money and so on and so forth. But then they don't reveal the nature of the full extent and scope of responsibility that you have. And this is difficult if you're a new doctor. Ideally, you need to have support. And eventually, I found that support in the partner model. I joined a practice where I was one of 10 partners. All of them were essentially more senior than me. They were more experienced, and they were very it was a multicultural practice, and so I felt well supported in that practice. 18,000 patients, for the practice with 10 doctors. That meant that we had a good cover in terms of, sick days and in terms of, workload, but it was still a very heavy workload. You had lots of reports to fill in, insurance forms to fill in. You had lots and lots of work to do day to day. You had lots of admin, and I would end up going back in on the Saturday or a Sunday to try and keep up with the administration, all the paperwork that you had. Because you see 32, 36 patients a day, you have phone calls, you have home visits, and the number of home visits is just a function of the number of people working on any day. So, for example, if you have a very busy day and there's 6 home visits or 8 home visits or 10 home visits, then you can split them between, say, the 4 or 5 partners that are working on that day. So you can imagine if it goes crazy and you have like 17 home visits, then you end up with 3 or 4 home visits per person, and that can be quite upsetting and quite overwhelming. So yes, but fortunately, the local sort of governance of the GPs in the areas that we work, they started to provide contracts for other companies to help us with some of the work that we had, which helped greatly, but didn't always, do everything that was necessary. And so you still had to do a lot of work. But yes, I was working out of hours, I was working in urgent cares, I was working evenings and weekends. But the problem is you've got a hard ceiling on the income that you can generate, the amount of compensation or remuneration that you can potentially ask for. And it felt like there was a never-ending treadmill of paperwork and sort of face-to-face duties. And then you had disgruntled patients, people who were upset that they couldn't get their hip replacements, that they couldn't get their medication, they couldn't get their operation, and they would sometimes be upset with you. And for the most part, most of the regular patients were fine. It was the locum jobs where you were an intermediate doctor covering for someone who was away, that there were always issues that would arise. And so the question was, why move overseas? And in terms of moving overseas, we always talk about push factors and pull factors. And in terms of push factors, one of the biggest ones is a reduced income. In terms of real terms income, over the past 10 years, or over the past 15 years, we can say, the spending power of doctors or medical staff or professionals in the country overall has been reduced. When you're living in London, when you're living in the UK, in London, you often, the amount of money you need just to survive is often quite high. And when you're dealing with something called black tax, that could make it more difficult. Black tax is a way of describing the additional fees that we pay, being second or first generation immigrants to this country. We have responsibilities overseas, we have responsibilities here, we have family that we need to help, in one way or another. And that means that you don't necessarily have a surplus of cash from month to month. You don't necessarily have a surplus of cash because you've got an extended family that you have to contribute towards or help, that our colleagues, our indigenous colleagues, may not necessarily face those same challenges. And I was really feeling like I was the squeezed middle. You felt that you were given a promise that you would earn a certain amount of income as a doctor, or you'd be in a position to do certain things as a doctor, but you weren't able to do those things. And then you have the sort of the real situation where you see that colleagues overseas doing a similar job with similar level of experience or knowledge are earning significantly more than you. And I was surprised to find that whether it's Germany, whether it's I think Switzerland, other places in Europe also pay their doctors more. So, in real terms, if you look at that picture, you look at all these different challenges, and then you look at these pull factors, higher income ceiling, greater opportunities. The market in the UK is saturated to a large extent. The job market, the opportunity market, but there are still opportunities, but there are more opportunities overseas. And that was my experience, and that was what I heard speaking to people who had made the move. So the options are, I think we're all familiar with them. You can work in either North America or the Middle East or Australia and New Zealand. I've not mentioned Europe because that's not maybe as exciting. It's not maybe as big as change, but Europe is still a very valid option, and lots of people make that move to work, in Spain, in Germany, and in Switzerland. So there's lots of opportunities outside of the UK. North America, I found it the most compelling because it was very competitive, two markets, so you can pivot more easily if you're in North America. They speak English, so pivoting from one to the other makes more challenge. Makes more sense. Middle East, yes, you can work in the UAE, Qatar, and Saudi. I've got relatives who've worked in Saudi for many years and come back, and they've done well. They've been happy. But there are also downsides. Okay. So, I had a real experience of working in -18 to -25 degrees Celsius. Again, you don't necessarily work in these temperatures. You maybe live in these temperatures, and indoors it's less of a concern. The roads are going to be the main challenge and barrier to getting to and from work. As long as the roads are clear, you're fine. But there is this culture of opioid use, and this is something that I found a bit strange. I mean, you hear about the opioid crisis, and it is a big problem. Lots of patients end up dependent and addicted to these very strong narcotics and these very strong medications. And they're on them for way too long, not as long as we would, longer than we would put them on in the UK. You got these extremes of temperature, freak weather, and a very aggressive society. And on the one hand, it's aggressive, but Canada maybe isn't as aggressive as the US for many reasons. There's political instability, there's prejudice and less diversity working in some areas. And then in Australia, there's funny accents, greater isolation, and then you've got a 24-hour flight to get home. So you can see there's benefits and negatives as well. In terms of making the move, I think the networking is most important. You need to have a lived experience, not just something you've heard about or talked about or seen online. You need to visit the place. You need to see the place, talk to the people who have worked there and people who are still there, and people who can tell you about what life is like and whether it's a good move for yourself and for your family. You need to register with the regulatory authority, and then maybe look for a job offer or join an agency. The good thing about having a job offer or joining an agency is once you have a job offer, you're in a position to apply for a work visa. Getting into the country, you can get into the country on a temporary visa, for visiting. But then if you want to work there, if you're working there for 2 years, 3 years, you need a visa. Unless you've got family who are already working there, and have a permanent residency or full citizenship, it can be difficult to obtain another kind of visa that you would need otherwise. So work visa is usually the most the easiest one to obtain, if you can provide the proofs of employment, the proofs of income, and so on through a letter of employment or through an agency that can pay the fees that are needed. Okay. General advice is that there are many opportunities, and you shouldn't limit yourself necessarily to just being in one country. If it's stifling your prospects and limiting your growth and the opportunities that you have for you and your family, as long as you're focused and stay on target, you can achieve and sort of end up in doing whatever it is you like to do, performing your vocation and your life work in somewhere where you are compensated appropriately. But yes, you need to leverage your network, because people who are in your network will potentially have had the experience that you're after, and would be able to give you a shortcut or shortcuts to achieving your dreams. But due diligence is important, because you make sure that you check and you verify, you double check anything that is such a big undertaking. But yes, one last thing. Business opportunities are like buses. There's always another one around, and essentially, you and your life is essentially a business to some extent. You have you have income and expenses. You have plans and forecasts. You have things that you want to achieve, and so you can consider the opportunities and the investment of making that move as potentially going into a bigger market and potentially being more, great, rewarded with more opportunities. So yes, I don't think you should limit yourself. But that is my talk. Okay, thank you. Um, I think we are approaching the end. It's nearly time for Dr. Muji. Dr. Muji?
Yes, I'm there.
Okay,
I switch
great.
off my video because of I'm not sure which internet, but we can go.
Okay, no problem. We'll get started. Now it's yours. Do you want to go ahead?
Yes. Yeah, thank you very much. So my name is Junior Muji Ekichak. I'm a family physician like Dr. Pidanch, a GP. It's a new discipline in DRC. So we are working to make it more visible and it can help with the country for primary health care. So because we see a lot of challenges, in DRC we have only 3% of specialists, and the other are just physicians. After they finish their medical school, they go to work without another training. So what we are doing with the Protestant University is to help people to train them so they can gain some other skills and help the country. So next slide. Next. Okay, so the situation I have described is based on our health system. So now we have so many challenges in DRC, we see them, but we are organized in three levels. The central level is the government. We have the Ministry of Public Health. They are in charge of strategies, regulation, policy. For example, if we need a new guideline for malaria treatment, it belongs to government to decide what treatment we need or what kind of policy for immunization or what policy for emergency situation. And then we have in each province, we have what we call health division. So they play a role of link or bridge between the Ministry of Public Health and those who are working on the ground. So on the ground, the peripheral level, we have the health zone where we have health centers and district referral hospital. So this is the way our health system is organized. So in the peripheral level, we have the health centers, the community health centers, and district hospital. But we can also add the tertiary hospital, like the university clinics and other private clinics, who can provide a very specific care. Next. Yes, this is yeah. This is how our system is organized. So normally people start with health community. If they want to enter in our health system in the village, mainly they should start with the health community. They are not these people are not really nurses or physicians. Most of them are just a teacher or in a village, and they are trying to provide basic care. For example, if a child has fever, so in the village, you go there, they can check for malaria and provide a treatment. And if it doesn't work, then they go to the health center. There we have the nurses who can do some more examination and provide treatment. This health community health worker are also in charge of immunization, maternal and child health, and so on. They can, and the nurse, they can also do basic consultation. Then we have what we call district hospital, like the hospital where I work, Vanga Hospital. There we provide some additional care. We can do surgery, emergency care, C-section, for example. But this is on the on the document, but in reality, you will see that even a small health center can do a C-section, can practice blood transfusion. That is not allowed. So these are challenges we have in the country. And we have in DRC some few hospital, what we call tertiary facilities like Kinshasa clinics, but we have a lot to learn because in reality, just the name, if you go there, sometimes you don't find the care you are looking for. Next. So, talking about the priority or health issue we have or challenges in our health system, I have divided in three. So the first one is provision of health services. The first one is the low coverage. So people, myself, I work in a rural region. People can work for 5 hours to find the first health center. So it's horrible. Can you imagine a pregnant woman in a very emergency situation that can work for 5 hours to reach the first health center? That's a problem. And once they arrive in the health center, the quality of care is poor because people are not really well trained and they don't have skills and they don't have equipment. And sometimes this referral system doesn't work. So these problems are really complex and difficult sometimes to manage. Our country now, DRC, we don't have a plan for how to manage outbreak or emergency situations. Right now in Kinshasa, we have a cholera outbreak. But what the government is doing, we have to wait for WHO or other big organization, UK, European Union to give some advice money, then we can start doing something. And then we have our health system support a lot of challenges. The distribution of healthcare professionals, for example, in Van Hospital, it's a hospital with 500 beds, but there are only 13 physicians. 13 physicians for this big hospital, while in an hospital in Kinshasa with the same size, we will find 200 or 300 physicians. And most of the time, people who are working in this remote region are not qualified with less skills. They don't have infrastructure, no equipment, no drugs. Yesterday, they called me to in the Van Hospital to let me know that they need malaria treatment. Malaria treatment should be there, but we don't have it. Sometimes we have to beg for other organizations to provide the treatment. And then the big problem, why we have this problem, the problem is the governance and management. This is the big problem we have in DRC with the lack of leadership. Next. Yeah, this is what I did during my master degree. I try to learn to analyze with a systematic thinking why we have this problem. So I'm more focused on maternal and child newborn care. So I try to understand why we have a high rate of maternal and child mortality rate. So you can see this, what I did. The key problem is the bad governance, corruption that leads to poverty, no financial resources, high out of pocket, no access to healthcare. So all the thing leads to a broken health system, bad governance, corruption. That's a problem we have in DRC. I hope that in the coming years, the leader will tackle this problem of bad governance and corruption. Because if we fight corruption, we will have more resources, a lot of money to improve our health system. We will train our physicians, we will train our nurse, we will equip our hospital health center, and then we will improve the quality of care we are providing to our population. Next. So these are the consequences we have. I have mentioned them. So the maternal mortality rate is really high. The same with child mortality. We have a heavy burden of tuberculosis among the 10 countries in the world. We are there. Malaria, we are the second biggest contributor of the malaria after Nigeria. And we have other many problems like neglected tropical diseases and so on. So next, yes, the country, so we cannot manage a lot of outbreak, low vaccination coverage, and now the population is growing. We have a lot of cases of hypertension, diabetes, cancer, but we are not prepared to take care of this problem. That's the challenge we have. And I can also mention sickle cell disease is really a major problem in rural as well in urban region. Next. Now, what we can do? What we can do? I know Dr. Pidanch is there with some other colleague from UK. I don't know how much of you have visited Congo. Dr. Pidanch came here last month, I think, in DRC. I don't know if Joyce, if you already been in DRC.
Hi, Doctor. Yeah, I've been there once. I need to go back. I've been once.
Yeah,
Yeah,
I
I need to
want
go
to,
back.
yeah, I know that it's not easy for you to come and visit DRC. So I'm traveling every quarter DRC to UK because I have
Mm,
some contact and doing research with Oxford. And I
mm,
will start a GPhil program in September with Oxford. The purpose is to improve maternal and newborn care in DRC. So I
mm,
ask myself, where can we intervene? Surely we cannot work with the government at this moment. It will be quite difficult. But
mm,
the majority of these big organizations are working with the government. Last month, I met MP in UK, Sir Gavin, because he is in charge of DRC in UK politics sphere, and we spent 1 hour discussing how the UK government can help the DRC. He told me that they give a lot of money, but they give money to the government, and money given to the government is used here in Kinshasa to buy big car, I don't know, a meeting and so on.
mm,
That money are just used in Kinshasa, but even here in Kinshasa, it's for rich people. It's not for the poor. He told me about Oxfam and other UK organizations. I don't think that we we can try to work with the government. We will fail. Intermediate level, I'm not sure, but in my opinion, we can work with those who are working in the ground, in the hospital, in the health center, for example, to train them how they can manage our nurses in hospital, in health center. They need the training. Last week, they called me in the hospital, asked me how I can find the training for them, how we can improve even just small intervention that can bring a huge impact. And we cannot work with the government. I think the good thing would be to work really with those who are working on the ground. We can start, for example, by implementing a good tool to collect data. With the data we have, then we can identify the big problem we have and design intervention that can be effective in the future. So this is what I prepare to tell you. Next slide. I put some pictures so you can have an idea. Sir, you can see in the left side, it's a maternity in a remote village of DRC. In the right side is where women are delivering, delivery home. You see how women come and deliver in this room. There is some, most of the time they don't have gloves. They use the same gloves several times. and you can imagine how risky it is to use the same gloves. So this is the idea. You can just find the idea what I'm talking about. Next slide. Yes. So in the what is the how our health system is divided in health zone. Now there are 519, I think, health zone, and the picture in the middle is Vanga Hospital, where I'm based, where I worked, our hospital, and in the right side is our delivery room. It's acceptable because we are there with our team. We try to improve it, but it's not enough. We are still working to improve the quality of care we provided to pregnant women in delivery room, and newborns. I think that this is the last slide. Thank you very much for your attention.
Okay, that's great. Thanks a lot for your excellent talk, Dr. Muji. I think that's the end of the slides.
Yeah.
So we'll just go back to the talk, and maybe if there's any questions for the panel. I've actually got some questions for you, Dr. Muji, if that's okay.
Yes. Yes. Okay.
So my question is because like you said, I recently I came to Congo, and when I was in the capital in Kinshasa, all I saw was big shiny hospitals, Chinese
Yes.
hospital, Indian hospital,
Mm-hmm.
the American hospital, Mutombo Dikembe, all these clinics. I saw so many, so I was encouraged. I was very happy to see that there were so many hospitals. And friends and colleagues I've spoken to have said that there's a lot of material in Kinshasa. There's a lot of materials everywhere. You can get scans, you can get CTs, you can get MRIs, you can get everything you want.
Mm-hmm.
And there's no need for for someone to try and set up a clinic here or there or to send equipment. But what is your experience? How can we, as healthcare professionals, doctors, nurses, or even allied health professionals, managers, what expertise, or because you mentioned, I think audits, I think it's an audit tool. I think that's what you're mentioning, an audit tool.
Mm-hmm.
Is there
Yes. Mm-hmm.
any other practical or intellectual information or things that we can do, like basic life support or defibrillators, or I mean, day to day or week to week, or like what would you say going forward we should try and focus on if we want to come to Congo to do something for, say, 2 days, a week, a conference, a course? What sort of thing would be most useful?
Um, so there are so many things. So for the first question, we have these private clinics for people from India, China. Uh, you see, they are not from Europe. They are from China. They are from India, and the first thing to know is very expensive. It's not for common Congolese people. It's just for those who are working in the government. So I think you can do everything. You can have a CT scan. They provide all kind of care, but who can afford this, who can go there for care? I think it's for a few number of Congolese people who have some money, or those who are
Mm,
working in the government or international organizations. We need a system for our population.
mm,
And for that, in my opinion, we need a good primary health care, working for prevention first,
mm,
and then prevention. If we work for prevention and we establish a good primary health care, I think we will resolve a lot of problems. What can be done? What can be done in DRC is like that, building a good primary health care system, and then specific clinics. For example, you can say in Kinshasa, if you need some care for heart diseases, can go to Kinshasa. If you need renal care, you can go to Vanga or another thing. So few big hospital, and mainly we need basic primary health care. and we need really to train our physicians. As I have said, only three, some said 2% are specialists. Now in DRC, there are 8 provinces without a specialist. So all the physicians who are working in this hospital are just general practitioners and without enough skills. So I think what we need is to increase the training, empower our physicians in the way of thinking, managing leadership, how to improve the care in the place they are working. This is my proposition. The first thing we can do, we can organize conference training, but maybe to start, we can just make a survey, as you say, ask to Congolese doctor, what do you want? What do you need? How can we help you? And then listen from themselves what they really need. And then we can step up to the next stage. But that is my opinion at this moment. I think we don't need to build big hospital with scan everything. At this time, we will fail.
Okay. Okay. Okay, Dr. Muji, thank you. Merci. Thank you. I'm not sure. Are there any other questions? Any other queries from anyone else?
Hi, Doctor. I just have one
Mm.
for Dr. Muji. Dr. Muji, thank you so much for that. Was very insightful, especially because we live here and we only have kind of the news and obviously our uncles and aunties that travel back and tell us like what Congo is like and from what their experiences and what they see. So thank you. That was very informative. I just wanted to ask a question on what you just mentioned now. I just wanted to ask if there's any kind of organizations or initiatives that exist already that we can support to enable the training that you mentioned for to encourage that specialists to train more and just to support their education. If there's anything already that exists that we can support, I can support, or just share with people that we can donate to or anything like that.
Actually, I'm not aware about an organization that is specialized on training, even short training, but most of these
Mm,
organizations work with the government. So, for example,
okay.
they send people in Vanga to train our nurses. But this kind of training, I don't like it because people
Okay.
from Kinshasa come with the first thing is money. So with
Mm,
money, just they take 1 week talking to people. They don't know what if people are really learning, how they will practice. It's not a good way of training people. I'm not aware,
mm,
but we still have the system of university. Kinshasa University is training specialists, but
okay.
with UPC, Protestant University in Congo, we are also working to train Congolese doctors, but our focus is to train for those who need to work in remote region. So myself with some colleagues, we have starting to build a small team,
Hmm.
but they will be focused to train people in management of newborn care in
Okay.
rural settings. So maybe in 1 or 2, I'm supported by Dr. Pidanj, met him last time in Oxford, of
Mm,
Mike. He's supporting me to build this small team. So we will start training trainers, and then this trainer will continue to sustain training in our health system, so we can work through the hospital or small health center, train people for the basic thing to do, how to do newborn resuscitation, how to provide the first care, how to make a referral, how to do a referral to the district hospital. So this is what we are thinking to do. But right now,
hmm.
if you want to an organization, I will check if it exists and I will let you know. But there is
Thank
also
you.
some hope.
Mm,
Every time I want to say about some hope, there is hope. The government, I think they are trying to improve the maternal, newborn, and child care because we have now free maternity in DRC, and now the government has started a good start point. I hope that they will improve it in the coming years because now there are so many challenges. They will improve it. Women can go deliver without providing money. So this is, we hope that they will improve what they are doing in the next 3 or 5 years. This is the hope I found now with the government.
That's promising. Thank you. Thank you so much.
Okay, I have a quick question, please.
Yeah.
I've seen that gloves is a problem. Basic equipment like gloves, syringes, and needles, and things like that. So, if we
Yeah.
had to provide that, for example, to send back home to hospitals, what would be the best approach? Because we don't want to gather those gloves and, I don't know, syringes and needles to take back home. And once you get to Kinshasa and someone get hold of it and then start selling it, what would be the best approach to do that, to help?
Yeah, I think the best approach would be to work directly with the main manager of the health center or the hospital. Because if you try to contact someone in Kinshasa, you are not sure, maybe he will use it for his own purpose, can sell it.
Yeah.
So maybe the thing would be to find a good person first, to identify a good person, and to then identify the clinics who are in need. Last time I was called for a small clinic that received a lot of material, and they don't know what to do with needle, syringe, glove they have. They have a lot, and they asked me if I can bring to the Van Hospital. I said no, I can't. So you see, we need in the one side to identify those clinics who really are in needs, and to find good person. We are sure that if we provide this equipment, it will be used to help people on the ground. Because there is a system, they call it pharmapoche. So if you, it means you have your, because people are not paid. Nurses, physicians are not paid. So they come with their own equipment in their pockets, and they say, okay, if you want an injection, give me $1, then I will give you the needles. I will use it for you. So we don't need to provide our equipment to someone who will use it that way. We need really good person, and those people exist. We can first identify these clinics, identify those person, and then we can provide these equipment. But never do that with the government. If you do that with the government, that's the problem. Yeah,
It
it
won't
will
work.
never rise. Yeah,
Okay.
it will never work. Yeah.
All right. Thank you, doctor. Thanks.
Okay. Merci. Okay. Yeah, I think if there's no more questions, we can maybe call it a day. I'd like to thank everyone for participating, giving up your time, giving up your expertise, and giving us very useful presentations. Whether it was Joyce or John, Dr. Muji, I think I've learned a lot and found it very useful and helpful. Hopefully it's the first, but not the last. But I wish you all a good a good Saturday, a good weekend. Enjoy the rest of your day, and I'll be in touch. We'll maybe talk in the coming days.
All right, doctor.
Thank you
Thank you
so
very
much.
much. I
Thank
will,
you,
Likewise.
everyone.
All right.
Thanks,
I will be in
everyone.
London in
Yeah.
September. Probably I will look for you,
Yeah, September I'll be around as well. My
Joyce and
son's,
John. We can
my
meet.
wife's traveling,
I
so
will be
I'll be
based in
around
Oxford.
in Oxford. Okay,
Okay.
yeah, okay. No, we'll be in touch. I'll message you. We'll try and sort something out. I definitely want to see you when you're back in London.
Okay. Thank you.
Okay, doctor. You have a good day. Thanks again.
Thanks,
Bye-bye.
everyone.
Bye bye.
Thank you.
Bye-bye.
Bye.
Bye-bye.